Hi, I'm Dr. Peter Sturm, Director of the Crawford Spine Center at Cincinnati Children's Hospital Medical Center. My elective practice is completely a scoliosis practice, and within that, one of my major interests is early-onset scoliosis. I've been involved in doing this for a number of years. We submit patients to both the Chest Wall and Spine Deformity Study Group and the Growing Spine Study Group. Have a lot of research going on in this area. We have a program that's based on early-onset scoliosis here at Cincinnati Children's. We have multidisciplinary conferences where we present children with early-onset scoliosis, and we have an early-onset clinic that's attended by both myself and one of the pulmonary doctors, and I think that really gives us a different perspective on these curves, because I think the pulmonary component of it is frequently overlooked and is frankly in lots of ways the most important part of that. We're hosting tonight's event because we've been hearing that families are interested in learning more about early-onset scoliosis and the different treatment options. I'm going to field as many questions from you all out there as possible. Feel free to start sending questions in, and we'll get to them as we go along. Please enter each question only once. If we're unable to get to your question, we'll send a follow-up email with answers to all the questions in the next couple of days. So we'll go to the questions now, and our question is, what is the difference between risser and metacasting? Risser casting was the most traditional way to deal with scoliosis prior to scoliosis instrumentation. It was not designed initially for young children. It was designed for scoliosis in general, and was used in kids with idiopathic scoliosis in adolescents, as well as younger children. It is a casting system that was based on three-point correction, and there was pressure put across the apex of the curve on the ribs to try to pull the scoliosis over. The concern with risser casting in younger kids is that we worry about chest wall deformity being created by the casting itself. Since the spine and the ribs are so plastic, we worry about the pressure on the ribs causing rib deformities and chest wall deformities as we correct the scoliosis. The Meadow or Cottrell or EDF casting is really a cast that depends more on derotational control, so that there's a gentle untwisting of the curve rather than that strong pressure across the ribs on the apex. There are people who still do use risser casting for early onset scoliosis. They've actually reported some good results. It's basically the same idea, but again, a little bit different in the execution. I think more people have switched to metacasting than risser casting, but risser casting is still around. The next question is, my son is 8 months old and as of April had a curve of 62 degrees. They said he's idiopathic. Do you think metacasting is the correct route, or would it be worth trying a brace first? And we have a couple of questions up already about bracing and casting. Let me say that we actually had started a study looking at casting versus bracing in idiopathic curves. And we were looking at centers that did bracing and centers that did casting, because I think there is a philosophical difference between the two groups, and we were going to compare our results. It's been a little hard to get the study going because more and more centers are going away from bracing and towards casting. Bracing in adolescent idiopathic scoliosis is well accepted. And there's mixed evidence in the literature, even in adolescent idiopathic scoliosis, about the effectiveness of bracing. And there's actually a multi-center NIH-supported ongoing study that's looking at the effectiveness of bracing in adolescents. I think there really is no great evidence out there for the effectiveness in bracing in early onset curves. And I think because of this, and because there is some evidence that casting does work in early onset curves, that more and more people are going away from bracing and towards casting. So in my practice, certainly, and I think in a lot of people who deal with early onset curves, an 8-month-old with a 62-degree curve would be a good candidate for casting, especially with an idiopathic curve. And there, again, there's not great evidence that bracing works. Making braces for very little children is difficult at best. It's certainly much easier to mold a cast than to mold a brace for a little person. Our next question is the casting bracing protocol to contain the curve for 2.5-year-old and then surgery at age 10 to 12 years to correct the curve? And I think the answer to that is no, and it also really depends on the curve itself. So we look, depending on the curve, to try to correct the curve completely with casting. And I think the evidence out there is that in kids under 3 with truly idiopathic curves, whose curves are initially 60 degrees and under, those curves we can improve to the point that hopefully no further surgery would be needed with casting alone. And again, of course, it depends. Each case is a little bit different, and it depends how the curve responds. But what most studies have shown at this point is that those curves are curves that we think that casting alone will get better. Bigger curves, then we may be looking at a holding action, but it may not necessarily be a holding action to surgery at age 10 to 12. It depends on the behavior of the curve and the size of the curve to start with. In bigger curves, we may be looking at a holding action for a few years and then switching to some other form of treatment, such as growing rods or vectors, to try to control the curve before children get to age 10 or 12. Next question is, have you seen syndromic hypotonic kids benefit from the metacasting actually correct the curve? And I think the answer to that is yes, but I think we need to be a little bit less optimistic with syndromic and hypotonic curves. The best results, again, are in kids who have truly idiopathic early-onset scoliosis. I think it depends on the syndrome and depends on the child. I have seen curves actually get better from the casting. It again also depends on the size of the curve. I think smaller curves and syndromic or hypotonic kids are easier to control. I think once the curves get bigger, casting again can be a holding action for the curve, but not necessarily curative. And that's not necessarily a problem. Or a bad thing. I mean, if the evidence seems to be if we can control the curve for a while and stop it from getting very big and then switch to some form of surgical intervention as the children get a little older, we probably have done a good thing even doing that. So just because we don't necessarily think that the casting is curative doesn't necessarily mean it's not the right thing to do at the start of treatment. So the next question is, my child is 8 years old, currently in a metacast. How old have you casted and what were the results? I think there's a lot of debate about this point and what kids should be going into cast, what are the best ages to cast, when do we get the best results. Again, casting can be a holding action for some kids who are older and put off surgery and put that a little further down the road. Remember that growing rods, vectors, any kind of growing technology, the results are actually good, but the complication rate is also fairly high. And it's not complications that stop treatment, but complications that make the road a little bit bumpier as you go along. And I think, again, the evidence is the longer the systems are in place, the more chances there are that there are going to be some form of complications. So I think in some children, if you can hold off the surgery until they get a little bit older, that still may be a good thing with casting. I think from a curative standpoint, casting works best in children under 4. And I think the reason for that is really actually fairly obvious. I think there's not magic with casting. I think what casting does is takes the curve and straightens them out and unloads the growth plates on the inside or the concavity of the curve and takes advantage of nature and growth. So if you can unload the curve and let kids grow out of the curve, you want to do that at the time where they have the most rapid growth. And it's between 0 and 3 that proportionally kids have the most rapid growth. So I think that's why casting works best in that age group. I think casting works better than bracing in that age group because, again, you can control the curve all the time. It's not that they're coming in and out of braces, and bracing doesn't necessarily give you as much correction. So once the cast is on, the curve is corrected within the cast, and then you take advantage of growth, and hopefully the children will grow out of the curve over time. My son, the next question is, my 5-year-old son has been in a Metacast for almost 2 years. They say now there is minimal spinal growth. How much of the spinal growth between 5 and 12 years on average for a boy? Are we better continuing the casting? Again, you know, there's not, first of all, I don't want to give people the impression that what I say is the right answer and that there are people out there who say other things and that's the wrong answer. There is a lot of room for discussion within this patient population and within these surgical techniques and non-surgical techniques. So there's not necessarily a right or a wrong answer, which is why a lot of us have very different approaches. And I know for some people that's not helpful because you're going to get very different stories from different people. You know, again, I think that over 4, there's less growth. And it depends on how the curve is responding to the cast, on the size of the curve, and what the other options are to decide on whether or not a 5-year-old belongs in a curve at that point, in a cast at that point or not. You know, at that stage of the game, if the curve is large but not getting worse, it may still be worth continuing to cast. And trying to hold off surgical intervention till further down the line. If the curve is moderate sized but isn't completely corrected, it may be time to start thinking about transitioning to a brace. There's really not a right or a wrong answer, and again, a lot depends on each individual curve and how it's responded to the casting up to that point. Again, my child is 8 years old, and the next question is, my child is 8 years old, currently in a Metacast. How old have you casted? What were the results? I mean, again, I think that it depends on the curve and depends on how the curve has responded and how long the person has been in the curve and what you're trying to accomplish. It's not unreasonable with a 7 or 8 year old with a very, very large curve to try to cast it, to loosen the curve up a little bit, to try to control it for a short period of time before switching to some other form of treatment. I also see there's a question there about whether bracing at the end of casting is different than bracing to start with, and the answer is yes. So I think most people, and again, I don't think there's a right or a wrong answer, but I think most people at the end of casting, when they've gotten good correction of the curve, switch to bracing for some period of time to try to maintain the correction. So in my practice, if we get the curve down to 15, 10 degrees or under, at that point we say we've really gotten the curve better, and we would take the child out of the cast and put him in a brace initially full-time and then transitioning to just nighttime for around a year afterwards. In other children where the curve has not responded quite as well but is more moderate size, it's reasonable to think about bracing for smaller curves around 20 degrees or so, and then transitioning again to nighttime bracing. Most people would not cast a curve of that size, so I think when we get a curve down below the size that we would think about doing casting, then switching to bracing for some period of time is reasonable. Next question is EDF casting advisable in smaller curves, 20 degrees, in older children 4 to 5 years old? And I think the answer to that is probably no. Again, remember, casting does not have a significant number of complications, but it is surgery. It is not invasive surgery, but it is a cast that's put on under general anesthesia. And if you could avoid multiple general anesthesias in young children, we certainly would be happier. So the things you have to weigh are what are the behavior and the natural history of the curve, as compared to the treatment. And most people would say that a 20-degree curve in an older child, in a child 4 to 5 years old, probably does not need any treatment at all at that point other than observation. And it's reasonable to watch that curve and see what happens. If the curve starts to get worse in an older child, 5 years and older, then bracing is probably not an unreasonable option for that child. Next question is, where do we go for great metacasting? And I think there are some good resources, and I think most of the people who are writing in probably know about those resources. There are a couple of parent support groups that are out there that are involved with early onset scoliosis that can recommend people who are doing metacasting. There are very good people around the country. There are a number of centers that do a lot of metacasting, and as I've said, I think more and more people are going towards the EDF or metacasting, and there are a lot of people who have been very well trained. Some of us were trained by Dr. Meadow herself, and then we've trained other people, so there are some really good people out there who are doing metacasting, and I think there are some good resources to find them. The next question is, does the most straightening generally occur in spurts, typically during casting? If so, are there typical series where this occurs, first cast, second cast, etc.? Again, each curve behaves a little bit differently. Some curves we get a huge amount of correction the first cast, and that correction stays. There are other curves where we get a little bit of correction, and then suddenly the curve really seems to come around. And I can't really give you a good answer as to why that happens. And I think, again, it's because each curve is a little bit different. So there are some curves I get very optimistic about early on because the first or second curve really gives us a tremendous amount of correction, and that holds. But what I always say to families is, if we have a curve that we think is going to be responsive to the casting, just because we don't get a lot of correction in the first couple of casts doesn't mean that it's not going to work. I think it's worth staying with it and just being diligent about the casting and just seeing what happens over time. So each curve really behaves a little bit differently. The next question is, my son is 2 years and 4 months old with a 70-degree curve. We're trying to schedule the MRI to rule a variety of things out. Just wondering what the best case scenario will be in terms of the MRI. Well, first of all, realize that in children this age, an MRI involves sedation or anesthesia because they can't sit still to have the MRI without that. That said, it still is worth it in children with large curves because there is a chance that there is an underlying problem going on inside the spinal cord. So the best case scenario is that there's a normal MRI. And this occurs in about 80% of kids. So it's only about 20% of kids with early onset curve who have some form of spinal cord pathology. And the spinal cord pathology that's most common is either a tethered spinal cord where there's a small connection at the bottom of the spinal cord that doesn't let the spinal cord move up as the spine grows and keeps the spine tethered down, or a syrinx which is a cyst within the spinal cord. And those are the things that you're looking for, but actually those only occur in about 20% of kids. So the best case scenario is a normal MRI, and that's going to occur in about 80% of children. So the next question is, our son is 4 with Prader-Willi syndrome. He has infantile scoliosis, a 14-degree curve on the upper part of his back. What would you do for treatment? Again, if that's the curve at presentation, I'm not sure that anything is necessary more than observation to start with. We know curves in things like Prader-Willi syndrome, syndromal curves, may not respond as well in the long run as idiopathic curves. But that's not to say that they're not good candidates for casting, at least even to try to control the curve to some degree. I think, again, it depends on the size of the curve and also the rib vertebral angle. Curves under 30 degrees with rib vertebral angles under 20 degrees may not get worse and may not get worse quickly. So I think most people would be content to watch those curves at first, see how they behave, and then switch to a different treatment modality if the curve is progressing and getting worse. Next question is, does Cincinnati Children treat congenital infant scoliosis? And the answer to that is yes. We actually see a lot of it. And let me just talk about congenital scoliosis as opposed to other forms of early onset scoliosis, be they either syndromal or idiopathic. Congenital scoliosis is caused by an abnormality of the vertebrae themselves. And that's a structural curve that's very different than non-congenital curves, again, be they syndromal or idiopathic. Those curves really do not respond well to brace treatment at all, even as kids get older, and the role of casting is a little bit controversial. Most people would say that congenital curves should be watched. If they're not bad enough to do anything about, they should just be observed, and if they're bad enough to do something about, then surgical treatment is probably indicated. But yes, we do see a lot of kids with congenital infantile scoliosis. Next question is, what is an idiopathic curve versus a non-idiopathic? So an idiopathic curve is a scoliosis in a child who has no other abnormalities, nothing syndromal, no hypotonia or low muscle tone. They are otherwise completely healthy kids who happen to have a curve. That's an idiopathic curve. When we talk about non-idiopathic curves, we talk about curves that are associated with various syndromes like Prader-Willi syndrome, which we talked about, or Marfan syndrome, or kids who have quote-unquote hypotonia. Those fall into a different kind of group and behave differently than the idiopathic scoliosis does. The next question is, how frequently should my child be checked if we are on a wait-and-see treatment plan? And again, I'm not sure there's a completely right answer. It depends how big the curve is, and it depends how the prognostic signs are. If the rib vertebral angle is not over 20 degrees, or is certainly a lot less than 20 degrees, and the curve is smaller, it's not unreasonable to check on the curve every 6 months. Unfortunately, anecdotally, all of us have had experience with curves that we didn't think were going to progress, and then they suddenly really took off, and over 6 months they took off a huge amount. So if it's a curve we're really concerned about, I think seeing you back every 4 months is not unreasonable. Again, the problem with lots of follow-up is lots of x-rays. And while x-rays are necessary to follow curves, we also try to minimize the number of x-rays that are being done, because we all know how much, we're all concerned about how much radiation children are getting by a huge series of x-rays. So again, while x-rays are necessary, we really try to cut down on the number of x-rays if we can. Next question is, my son's curve is to the left. Is this abnormal? If so, what would this be an indication of? So in adolescent idiopathic scoliosis, right-sided curves are much more common, and left-sided curves can be associated with intraspinal pathology. In infantile curves, actually left-sided curves are probably more common than right-sided curves. So in an early onset curve, just having a left-sided curve is not necessarily anything indicative of the fact other than that you have an early onset curve. Next question is, you've ever heard of a child having a normal MRI and then later finding out that the MRI missed a tethered spinal cord? So tethered cords don't develop over time in kids who didn't have them before, unless they have something like spina bifida, and in those cases the cord can become more tethered over time. Sometimes tethered cords are extremely subtle when kids are very young, and that may be missed, and then it may become more obvious as the child gets older. But the fact that the cord was tethered was probably there all along, but again, sometimes it's just very, very subtle and a little difficult to tell on some MRIs when children are very, very young. Next question is, my daughter's curve was 90 degrees when first casted with 16 months. She went down to 15 cast and is held at 50 degrees in her fourth cast. Have you seen high curves been cured with cast treatment? And again, my answer to that is I'm less than optimistic. It can happen, but the actual cure of the curve for a 90-degree curve is probably asking more than the cast can do, although there are, people will tell you there are children they have had whose curve have actually gotten completely better. So I think it's not unreasonable to hope, but I'm not as optimistic. And again, just because the curve is not going to get completely better, depending on the age of the child, casting for a while before some other form of treatment, be it growth modulation or growth technologic surgery, is probably not an unreasonable thing to do. And again, remember, I mean, we all very much want to avoid that as much as possible, but growth sparing surgery and growth modulation surgery are really not bad answers to the problem. So while we like to try to put it off, as I said, as long as possible, because we want to try to have as short a period of time with the rods in as we can, it still is a good treatment and is necessary in a large number of early onset curves eventually. Next question is, what are the pros and cons of the different treatment options? So again, the pros of all of the treatments are to control the curve. The best thing about casting is that it doesn't involve a surgical intervention, although again it is treatment under general anesthesia, so it is multiple general anesthetics. If it works and it controls the curve completely, that's wonderful. If it works as a holding action until children get bigger, that's also very worthwhile. The downside to any of the surgical treatments is that there are multiple surgeries involved at this point, because growing rods without actually going in and surgically lengthening the rods are not readily available in the United States these days. There have been some small number of them done, and we're hoping to be able to do more of them, but as of right now, those are not done. The FDA has not approved those. They're harder to get, which makes using them more difficult. The pros to growing technology is that we can control the curve and let children continue to grow. And again, as I talked about, I think, and this is where the pulmonary issues come in, the reason that we don't like to do early fusions is not the spine, it's what the spine's attached to. And I think, again, we all lose sight sometimes of why we're doing all of this and why we're trying to control the curve. We're really trying to control the curve to support pulmonary function. The spine is attached to the chest. As the curve gets very much bigger, it affects the space available for lung, and that makes it difficult over time for children to breathe, and we worry about pulmonary issues in the long run. There are some good studies that have shown that early fusions over a long portion of the spine lead to diminished pulmonary function in adulthood. So we're straightening out the curves to try to make sure that the spine grows and the chest grows, and then we diminish the chest growth by doing a fusion. So the advantage to any of the growing treatments is that we can control the curve and still allow the chest to grow, allow the spine to grow, and have space available for lung as children get older. Each of the different treatment modalities has various different downsides. I think with any of them, the biggest downside is we know that there is a high complication rate. Again, the number of catastrophic complications that really are unfixable, fortunately, are very small. But things like hardware dislodgement and infection, certainly the risk is there with any of the treatments. The good news is those usually don't affect the long-term outcome of the treatment, and we can continue along with the treatment as we've gone. I think when you look at vectors and growing rods, there are people who do both of them. There are people who do one or the other. There are arguments to be made for both. The concern with growing rods is that multiple distractions over time can cause stiffening of the spine, and we worry about autofusion and ending up with a stiff spine after treatment. I think Vector hopefully avoids that, but we also don't have great evidence about what Vector does to the chest itself over time. We know we can grow the chest, but are we making a stiffer chest as we use the vectors? That's something we don't know the answer to, and something we're not going to know the answer to for a long time until we really follow children out who've had these devices put in, and we're able to really follow them long term. Next question is, what is a vector? A vector stands for vertical expandable prosthetic titanium rib. It is a device that was originally developed in San Antonio that goes from the spine to the chest. So the fixation point, rather than being spine to spine, is from spine to the ribs, and theoretically it can control the curve by expanding the chest and the ribs and not being attached to the spine itself completely. Vector is a specific form of rib-to-spine technology, but you can do that same concept and not use a vector. You can actually use other types of rods and do the same thing with it. Next question is, how do you feel about alternative treatments such as clear and also using chiropractic care? I actually can tell you that I have no idea what clear is. So if whoever sent that question can be a little more specific, maybe I can speak to that more. Chiropractic care, I will tell you, in early onset scoliosis and any form of scoliosis, there is really no good evidence that chiropractic care affects the natural history of scoliosis, and certainly not in early onset scoliosis. I think that remember again, as we talk about all of this, that 90% of early onset idiopathic scoliosis we know will get better by itself. So 90% of kids with early onset curves have curves under 30 degrees and Meadows angle less than 20 degrees, and those curves will get better just with observation. So things that are done don't necessarily affect the natural history, and if we put a kid like that in a brace or do chiropractic care or do whatever we want, if we chant over a child like that, that curve is going to get better, and it's not necessarily our treatment that's made the curve better. You really have to look at the treatment versus the natural history. And certainly for curves, for progressive early onset curves, there is no evidence whatsoever that chiropractic care works. Next question, is there any new research regarding genetics and idiopathic early onset scoliosis? We have 3 children with idiopathic scoliosis that are interested in current or future research. That's a great question, frankly. Most of the genetic research at this point has been in adolescent idiopathic scoliosis, and I think we're getting closer to the causes of that. There has not really been a lot of genetic research at this point in early-onset scoliosis, and I think, again, early-onset scoliosis is a little bit more of a mixed bag than adolescent scoliosis is. Our hope is that once we get the answer in adolescent idiopathic scoliosis, that people's focus will start to turn towards early-onset scoliosis. And I think certainly it's not there yet, but I think as we go forward in the future, we will be getting the answer genetically to what's going on with scoliosis. Again, remember, we really don't understand scoliosis very well. Be it early onset or adolescent, I mean, we don't understand why curves behave the way they do. We don't really understand what causes the curve in the first place. We're not sure what goes on a cellular basis, what signaling pathways within the vertebra with vertebral growth and the discs are involved. We're actually doing some animal model study, studying at Children's in Cincinnati, trying to look at what goes on and what signaling pathways are involved, but we're really not even close yet to understanding what happens in scoliosis and in curves and why they behave the way they do. Again, the next question is, how common is idiopathic early onset scoliosis? How many cases are currently being treated at Cincinnati Children's? So people who have kids with early onset scoliosis and go to centers like Cincinnati Children's, where we do a lot of it, would think that it's fairly common, but it actually really is fairly rare. Places like Cincinnati Children's and other major children's hospitals that have early onset programs see a lot of kids with early onset scoliosis, but it still is fairly unusual. Remember, adolescent idiopathic scoliosis is much, much, much more common, and that's 2 in 100 kids. So it's not so common, but the places that do a lot of it see a lot of it. Next question is, how do I know when the cast is ready to be changed because it's too tight? We are recommended to change every 4 to 6 months because he is older. However, that is a large window. So again, I think the formula we use is really age-based. So kids under 2, we change every 2 months. Kids between 2 and 3, every 3 months. Kids 4 to 6, older 4 and older, usually every 4 months to 6 months. Again, because children aren't growing as rapidly. You can tell if the cast is getting tighter, if your child, who's an older child, starts complaining that the cast is tight, or if they start having difficulty with eating, if they have difficulty keeping food down, then obviously the cast is getting too tight. But, you know, depending on the age, again, and how large the child is and how rapidly they're growing, I know it seems a large window between 4 to 6 months, but it's not unreasonable to have a window like that. Next question is, what type of support does your center provide for families? So we have spine nurses who are involved with all of our patients. They're the ones who actually schedule the surgeries. They are in touch with the families between surgeries, preoperatively, walk families through the casting and, if more than casting, operative periods. We have videos that families watch prior to treatment. We have a nurse liaison who has actually been through surgery herself, who is involved with the educational portion of our program. All of us who do spine surgery at Cincinnati Children's have our own clinic nurses as well, who are very well versed in surgical treatment and in casting treatment, and are in touch with the families. So there is a very large support system involved with the families and with patients, which thankfully, because, you know, you'd rather hear it from the nurses than from us. They are much more available and are readily reachable, and they are the first line with families. That's not to say that the surgeons aren't involved with families as well. I mean, we keep an open line of communication with families. If the nurses can't answer questions, we are always readily available and try to speak to families as much as we need to. I think we answered that one already. Next question, is there a test like Score for early onset scoliosis to predict progression? So first of all, Score is a genetically based test that is based on being able to spit into a cup and then have a DNA analysis done on that with certain markers being looked at to tell whether or not a curve can progress. That's based on genetic probands in children with adolescent idiopathic scoliosis. It has been shown to be predictive of curves that are not going to progress. It's not as reliably predictive of which curves are going to progress. And again, this speaks to the genetics of curves, so that while we're getting closer with adolescent idiopathic scoliosis, we're not there with early onset scoliosis, and there is not a genetically based test at this point for early onset scoliosis. Next question is, you have one child with idiopathic scoliosis, who would be more likely to have another? Again, the genetics is complicated. The incidence is certainly higher than in the general population. Incidence in the general population, again, of adolescent idiopathic scoliosis is 2 in 100. Incidence in families of first-degree relatives is probably closer to 20 or 25%. So yes, there is a higher chance, but there's not a 100% chance. The other thing is that curves behave differently, so that different people in the same family who are related who have curves may not have curves that behave the same. I think it's more unusual, actually, to see families where every curve behaves exactly the same. Some families we see where mom had a 65-degree curve that needed to be operated on, and daughter has a curve that never gets up above 20 degrees. So again, there's a genetic link, but it's not very clear. It's very multifactorial, and while there is a higher risk, the question is how much higher that risk is. Next question is, can a curve greater than 30 degrees get better on its own? The answer is probably yes. Again, I think the rib vertebral angle is as predictive as the size of the curve. So there can be a 30-degree curve where the rib vertebral angle is not as high, and those curves do have a chance of getting better by themselves. Again, these are things that are prognostically predictive. So not every curve behaves the way they're supposed to. And again, 30-degree curves without an increased rib vertebral angle or significantly increased rib vertebral angle certainly can get better by themselves. Next question is, what age is recommended for spinal rods? And again, I think that depends on the curve and how it's behaving. And depending on what type of rods. I mean, again, growing systems, be it either a rib-based system or a spine-based system, depends on the size of the curve, the size of the child, what's happening with the curve. So we've done rods in children as young as age 2. I mean, we like to try to avoid it, but if we have a curve that's very large when we first see it, that's not responding to casting, in that we're not even being able to hold the curve, that the curve is getting worse, sometimes our hands are forced. So again, each curve is different. I'm not sure there's a right age or a wrong age. It's probably better to try to put it off longer if we can, but sometimes we can't, and sometimes we need to intervene earlier. Next question, am I familiar with an occult type phylum causing scoliosis? Again, the incidence of intraspinal pathology of some form, be it a tight phylum or a syrinx, is about 20%. Again, what the relationship is between those and the curve, we don't really understand. Since we don't really understand what causes the curve and why it behaves the way it does, the relationship between either that tight filum or the syrinx, we don't really understand why that causes the curve. But yes, certainly we know tethered cords are associated with early onset scoliosis. Next question is, we've heard of lots of kids with infantile scoliosis that also had severe reflux. Is there any research or link between infantile scoliosis and severe reflux? That's a very good and very interesting question, and I'm not sure what the answer to that is. As far as I know, there is no ongoing research looking at that. Certainly, I think all of us who take care of kids with early onset scoliosis would tell you that a large proportion of our kids do have reflux. And that's something that's probably worth looking at. Again, is there a genetic link? We don't know. There may be. But I think it's really something that's worth looking at and something that's worth trying to categorize. And I think at places like ours and some of the other large centers that do a lot of early onset scoliosis, it would certainly be worth looking at. Next question is, can you explain the ribvertebral angle? Is that a bone? So I think most people out there who are asking questions have heard of the ribvertebral angle. What it is a measurement that compares the ribs on one side of the center of the curve to the ribs on the other side. And actually what it is really is a measurement of the droop on the outside of the curve or the convexity. And why that happens, we don't really understand. Dr. Meadow first described it, and it does really seem to be predictive of curve progression. But it really is just a measure of the ribs on one side doing this as compared to the ribs on the other side. Why that should cause the curve to progress, or what exactly it is that causes that, what exactly it is about the curve that causes that, we don't really know, we don't really understand. Next question, is there a connection between having torticollis and scoliosis? So the answer to that may be true, unrelated. There are kids who do have torticollis who have scoliosis. There are actually a fair number of early onset kids who have torticollis as well. And we're not talking about congenital vertebral torticollis, we're talking about congenital muscular torticollis. What the connection is, we don't really know, but there certainly does appear to be a slightly increased incidence of kids with torticollis and kids who have scoliosis as well. Next question is, my 6-year-old son is in a brace. His rib hump appears to be getting smaller, but his chest appears to be more prominent. Is it possible his curve is rotating while in the brace? And the answer to that is yes. I mean, curves can get worse both rotationally and size-wise while they're in braces. It's interesting that the chest is becoming more noticeable while the rib hump is becoming less noticeable, because really the rib hump, to my mind, is the best measure of rotation. And if the rib hump is getting better, then to me that speaks to the fact that the rotation is getting better. Some kids with scoliosis do have pectus issues, either pectus excavatum, which is a scooped-in chest, or pectus carinatum, which is a chest that goes out, or they can have some rotational deformities of their chest, and those don't necessarily behave the same way as a curve does. So it may be that she does have a little bit of chest wall asymmetry, and that's getting a little bit worse, even though the scoliosis rotation is getting better at the same time. Next question is, if you do not believe a curve can be brought to zero through casting, at what point do you move into a brace? Is there still the expectation of a curve if kept under a certain degree? So first of all, I do believe that a curve can be brought to zero through casting. And in those kids where we've actually gotten the curve better, or to 10 degrees or less, or to zero in the cast, at that point, once the curve is controlled and we know that the curve is at that point, then we would switch to a brace. And again, that brace would be starting off full-time and then transitioning to nighttime, and the person would be in the brace, child would be in the brace for a year. Is there an expectation of a curve if kept under a certain degree? I think the answer to that is a little bit less clear. If we get a curve down to 20 or 25 degrees, say we have a curve that starts at 60 degrees and we get it down to 20 or 25 degrees, as a child gets older, how is that curve going to behave? Is it going to behave any differently than a child who presents at age 8 or 9 with a 20 or 25 degree curve? I'm not sure we really know the answer to that. So those are children that we probably would keep in braces for a longer period of time. We may switch them to part-time wear, but I would think, certainly in my hands, in my practice, a child who we start at 60 degrees at age 2, who we get down to 20 or 25 degrees, and we see we're not making further progress with the curve at that point, we would switch them to bracing and certainly think about keeping them in a brace for a much longer period of time. Next question is, does physical therapy help kids between casts and braces? Again, I think the role of physical therapy is a little bit unclear. There's not great evidence that by itself, certainly it can control scoliosis. In older kids who we put in braces, so in adolescents who we put in braces, we put on a physical therapy program just to keep their back muscles stronger. I think that makes sense in younger kids as well. But I think it really is an exercise program, and I think the kids need to be old enough to cooperate with the program for it really to be effective. Next question is, how come more centers do not offer EDF casting as a treatment option for early onset scoliosis? I think more people are starting to offer casting and EDF casting as a treatment for early onset scoliosis. Again, I think it's it's kind of like the Ponseti method for clubfoot casting, and I'm sure people have heard that analogy. Dr. Ponseti practiced in Iowa for a very long time, and while lots of people were doing surgery for club feet, he felt that casting was really a better way to do things, and originally was viewed as a little bit of a heretic, and I think now Ponseti casting is really the standard of care. I think, again, with early onset scoliosis, I think it's becoming, EDF casting is becoming more and more accepted. Dr. Meadow was a voice in the wilderness for a while, and she came to the States and has taught some of us how to do it, and we've taught other people, and as we've reported our results, I think more and more people have become interested, and I'm hoping that it will continue to grow in its acceptance, and more centers will do it. Remember, it is very labor intensive and really takes a good support team for it to be done effectively. Next question is, my daughter's numbers at 8 months were Cobb 26, RVAD 22. Her second x-ray showed a big improvement in Cobb to 15, RVAD to 10. The second x-ray is done with her standing, but her arms were out to the side and up. How big a difference can the position during the x-ray make on the improvement? I think positioning in very young kids makes a big difference. We'd like to take x-rays standing up or sitting, because I think that gives us really the best picture of where the curve is. Supine x-rays, lying down films tend to correct the curve to some degree just by taking gravity out of the equation. I think if a child can't really balance themselves and mom or dad is holding the child up during the x-ray, that's putting a little traction on the curve and can be affecting things. I think in very young kids who are just standing on their own, sometimes they may be standing up straight, sometimes they may be leaning into the curve a little bit, and people don't really appreciate that at the time the x-ray is taken. So I think position, especially in very young kids, can affect the curve to some degree. Next question is, will my child be able to have a normal childhood, play sports, etc.? And the answer is hopefully yes. I mean, that's why we do all of this. We really want kids with early onset scoliosis to have as normal a life as possible. people who've had kids in casts see themselves how much their kids can do in the cast. Once the curve is corrected, we expect kids to have a completely normal childhood and a normal life. And even children who have had growing rods and vectors, we let play most sports. So the answer is yes, we want kids to have as normal a childhood as possible. I think at this point we're only going to be answering another few questions. So if anybody else still has questions, please keep them coming, and we'll try to get to as many of them as we can. I think we did that one already. My assistant off camera here is getting a little bit dizzy at this point, so just excuse us for a minute. So again, what is the ideal time for cast change? And I think we addressed that some. It's really, there's not definitely a right or a wrong answer. I think it's really dependent on the age. So 2 and under, again, because kids are growing so rapidly, every 2 months. Between around age 3, every 3 months, because it's not growing quite as rapidly. As we get out towards 4, every 4 months. And I think that's usually the protocol most of us use. Next question is actually not really, looks like it's not really about an early onset curve. It's, my 14-year-old son was diagnosed with a 22-degree curve in January. As of March, he's been wearing a Boston brace 21 hours a day. His Risser score is 0. He's getting 80% correction of the brace. What happens after bracing is complete? Will his curve hold? So again, adolescent idiopathic scoliosis is a very different animal than early onset scoliosis. Brace treatment, for the most part, has been shown to be reasonably effective. And most kids, about 80% of kids who go into braces, the curve does hold. So what we would expect a 14-year-old with a curve of that size, that bracing has a really good chance of being successful. I think next question is, so with metacasting, you want to see how the Cobb and RVAD numbers decrease. Would this be indicative of both the curve and rotation getting better? The relationship between RVAD and rotation is not so clear. There's something that's called phase that shows the relationship to the ribs to the vertebra that really is more of a marker of rotation, and there's phase 1 and phase 2 curves. Usually when the Cobb angle is getting better, the rotation is getting better as well. Rotation and the size of the curve do not correlate as well as we think they would. There are some very big curves with not a huge amount of rotation. There are some smaller curves with a lot of rotation. And I think that curves that get better, the rotation tends to get better as well. Again, we've kind of mentioned the way that our center works, and that we have the spine nurses involved, and we've done videos. We do have a metacasting video that's available on our Facebook page for anybody who's interested, and that is something I think that for a lot of people who have questions can be very helpful. Next question is, do I believe that scoliosis can be caused by environmental factors, oral curves, genetic? That's a great question, and we don't really know the answer to that. There has been some evidence that congenital curves certainly can be affected by environmental factors. There's been some research in mice, but whether that really is going to hold up in people, we don't really know the answer to that. Do all curves have a genetic basis? Are all curves inherited? Probably not. There are probably mutations that occur, but why those occur, we don't really understand. Is this session available in replay? And the answer to that is yes, it will be available in replay. and the video will be posted on the chat page shortly after the broadcast. I'd like to thank everybody who sent in questions and who stayed with us. Further questions can be sent by email to the Crawford Spine Center, and our email is Crawford Spine Center, that's one word, at cchmc.org. A nurse will answer your question within 48 hours, and again, if they can't answer the questions will be passed along to one of the physicians. Again, thank you everybody for participating.